Welcome everybody to Health Tech Net. My name is Dr. Nick Van ter Hayden. I'm a principal at ECG Management Consulting, and we are delighted to welcome everybody today. Just a few reminders before we kick off the program. This program is being recorded, and if you want to chat or ask questions, please do so by raising your hand, or indeed just you can speak up. You have control of your own microphone. If I notice anybody that's causing background noise, I will mute you just to keep things moving along. Please note that the chat function, whilst you might think it's private, is not fully private. So please be aware that it potentially is available to everybody at some point because all of that gets downloaded. So just be aware of that. Otherwise, welcome to the program. Over to you, Jim.
Okay, thank you very much and welcome. I'll be very brief. I'm looking forward to today's program, and I don't want to take any more than minimum time out of it. I do want to let you know that we have the February program lined up as well. And big thanks to Lloyd Brodsky and Joe Bormel, who have been doing a lot of work on that program. I'm searching for the right way to describe it, and the way I'm describing it now is intelligent analysis of data can lead to useful conclusions, something like that. But we're going to have a policy-oriented presentation. Lloyd's going to do a presentation on dashboards and predictive technology, and our friend Dr. Farouk Alimi from George Mason is going to present the findings of a research project that he had published in Lancet about ways you can use data to predict the best use of antidepressants given patients' individual profiles. So we think it ought to be really interesting. Stay tuned for the announcement and the specifics. But with that, I want to turn it over to Deanne Kasim, who has done all the organizing and leadership work for today's program. So thank you, Deanne, and take it away.
Jim and Deanne, if I could interrupt for just a second and add a few comments.
Sorry.
First, we're delighted to have Deanne and Genevieve and others from Change Healthcare. We have the privilege and the pleasure of working with Change Healthcare on an almost daily basis. My partner Jennifer Farrow is on, and we're as well. She's from our government relations group, and we're doing work with Change Healthcare in all phases of government relations. And this is a particularly important subject to people who are in government. On a housekeeping basis, and Jim, you and I have talked about this,
right.
We're sort of stuck in the virtual world during Omicron, partly because of Nelson Mullins' rules in DC about having outside meetings, not to mention the fact that and this is good news, that Nelson Mullins conference room, the rotunda, and some of the other spaces being renovated with significant improvements in the AV system. So that will go on for a couple of more months, but February's meeting, Jim, I guess is going to be virtual as well.
Yes.
And we have a program committee meeting coming up over the next several weeks to discuss what future programs we'll be covering. And if you have any ideas or thoughts, feel free to let Jim or me know so that we can crank those into the discussions. As to dues, we're still considering how to handle that. As most of you know, most of the dues are, the purpose of the dues is to provide lunches. And sorry, we haven't figured out how to do that virtually in any nutritional way. But down the road, we're hoping that things will open up, and in terms of being able to have in-person meetings. So we're still trying to figure out what to do about the dues, whether to do the abbreviated version like we did last year, or something more substantial to cover the costs of meals. But we'll get back to you on that. And if you could just sort of hold on it and keep it in the budget so that when we do make a decision, the money won't be spent elsewhere. That would be helpful. So Jim, unless you will have anything more on housekeeping to add, Deanne, we will turn it back over to you, and thank you very much for organizing this presentation.
Sure. Thanks, David. Thanks, Jim. Let me just share my screen again. Does everybody see the slides?
Got it. Yep.
Okay, great. I always ask, between Teams and Zoom, it can be a little confusing sometimes. But yeah, appreciate everyone being here. I'm Deanne Kasim. I lead the Government Affairs Department of Change Healthcare. And as David mentioned, work very closely with David and Jennifer Farrow on a daily basis, tracking state legislation, federal legislation, and regulations. And of course, one of those being an important topic of value-based care and value-based analytics. And I'm joined today by Genevieve Morris, who runs our clinical interoperability strategy and works on our clinical document collector product, which she'll talk a little bit about, because of course you really can't have value-based care without data, and you really can't have enough data without it being interoperable. And then second, our speaker, Dr. Samarpal Kalan, he'll be joining us a little later. He also runs our value-based care analytics group called Prometheus Analytics. That's a group that we acquired. So we'll be talking about how that really empowers the next generation of value-based care models. What I wanted to do is just set the table on where a year into this administration, CMS and CMMI are in terms of their strategic plan, what they've come out with in terms of their strategic pillars, and specifically the direction that CMMI has publicly stated in terms of where they see their focus and where they see models moving forward. And if I can advance my slide, oh, there it is, a little bit of a lag. So far, where we've seen CMS come out publicly with their strategy is, we know that this entire administration came in with a focus on advancing health equity. In fact, you may have heard Nikki Tripathi, the national coordinator at ONC, call it equity by design. And if you, I'll make the slides available, but there's additional links in here if you wanted to drill down in what CMS has published as their strategic plan. But of course, first and foremost, they want to refresh where equity will fit in with Medicare. And that included in that will be more of a focus to move care upstream. To what that means is, before you actually get to people that are chronically ill, let's focus on how do we do more action with social determinants of health. And there's a whole bunch of research being done in the industry between the Gravity Project and other groups on how to make that data more interoperable. But specifically, CMS has said they want to focus on how to incorporate a lot of that social determinants of health additional care with ACOs and Medicare Advantage plans through those different funding models. They also want to modernize their payment policies. And in particular, there's a focus with this leadership on how do we make healthcare more affordable? What's the end cost? As well as how do we make that cost of care more transparent? And that really fits along with the work that the previous administration did on making those prices more available to the end consumers. So transparency is of cost is definitely a bipartisan issue. They've also wanted to double down on how to make it more person-centric and drive the quality improvements. And so we see that through what they'll be focusing on is how do we use those policy levers of Medicare Shared Savings Program, or MSSP, the next generation ACO models in particular. And they've publicly stated that their goal is to have 100% of folks in original Medicare, which is fee-for-service, to have a care relationship with accountability for quality and total cost of care by 2030. So they're really using those payment models as the lever to have that care continuity, with primary care being a big focus. And like I said, there's a link with the slides afterwards if you want to drill down on that publication. I mentioned affordability and sustainability. You may have heard publicly mentioned about the Medicare Trust Fund running out of money. That is definitely on the new administrator, Chiquita Brooks-LaSure's mind. And so actually started in the former administration looking at an RFP to put in the next generation of AI-enabled technology at CMS to be proactive and predictive for fraud, waste, and abuse. And lastly, on the slide, engaging their partners. There's been a real open listening session, and I call it a roadshow, although it's been virtual, of course, for the most part, CMS realizes they can't do it alone. They have done, I think, an incredible job meeting with coalitions, meeting with stakeholders to really listen to what some of the concerns are and put that into their strategic plan as well as their next models. So when I look at what CMMI has said in terms of their strategy refresh, and again, Liz Fowler, who heads CMMI, has done a great job speaking to a whole bunch of stakeholder organizations, including the Healthcare Leadership Council, which Change Healthcare is involved in, as well as AHIP and others, to really get some buy-in from not only the stakeholders, which she realizes they're going to do, that they need to rely on these stakeholders to make this work, but also hearing what some of the concerns are. And so where CMMI has publicly landed in the last month or so has said that, as I mentioned, all beneficiaries will be in a relationship with accountability for not only fee-for-service Medicare, but as many Medicaid beneficiaries as possible to get into those types of models as well, with care continuity, primary care relationships, and also financial accountability for quality and cost of care. We know that equity is a priority, and so one of the things they've said is all new models will address underserved and safety net providers, as well as collect race and ethnicity data. We're also looking at patient-reported outcomes. That will be in all models, which I think is definitely a shift, and it'll be interesting to see how we put the data capture and analytics behind that to make that part of the equation. Same thing with, as I mentioned, affordability. Price of care, affordability, and concepts of what might be waste will be included in all those models. Certainly a requirement for analytics to also keep that in mind. And then I mentioned the partnerships that they're looking to put in place with the private sector. So there was a question about what about current models? And Liz Fowler was very specific a few months ago on her stakeholder call that they will not end any current models only. There may be modifications, but nothing will be discontinued before its planned expiration. What you can expect will be a bolder approach, in her words, to testing and streamlining models. And I know that some of the stakeholder feedback, particularly from payers and providers, has been that in the past, there has not been enough testing or streamlining or really transparency of models to the actual plans and providers that have to carry that out. And that was something that Liz said she heard loud and clear. And also an administrative burden. So that is something that I know the stakeholder conversations I've been a part of had mentioned that loud and clear, and Liz has acknowledged that in her public comments. Specialty care will be included in episode-based models, and I know that CMMI is looking at analytics to carry that out on their end, with population health and health equity measures being included in that. The key way of engaging, you can look to CMS's LAN or Learning Action Network, and that will be how they see their key vehicle for stakeholder engagement moving forward. And lastly, when can we expect a new model to come out? Well, the Unified Agenda that was published in the fall has an August expected date for the next proposed model for Medicare. And with that, I will stop sharing my slides. Genevieve, I'll hand it over to you.
All right. I can figure out which screen to share. There we go. All right. So I'm going to talk primarily, and Summer will talk when he gets on about the analytics and different things like that, because that's really his area of focus. As Deanne mentioned, and I know a lot of you folks from my time in DC, interoperability is really my area of focus. I'm having I'm not gonna lie, I'm having a pretty good week when it comes to interoperability stuff. Sometimes policy you work on takes 5 to 10 years to see the light of day, but I think we're finally starting to make some progress. But what I'm going to talk about a little bit today is what we're doing around interoperability. And I will say our first set of products around clinical interoperability. So we have our service stack where we are the Commonwealth service provider. If you're familiar with that national network, we do all the technology infrastructure for them. And we've been doing that for, I don't know, like 6, 7, 8 years, really long time, at least in our world. But based off of that success, we've launched our first product into the market on clinical interop that really focuses on the payer space, which makes a lot of sense because as Change Healthcare, that's where we spend a lot of our time. And so what I'm going to talk about a little bit today is our clinical interoperability plans and how we're supporting payers, and particularly as they start to move more into value-based payment models. And certainly for our group, Medicare plans are a fairly large focus because not surprisingly, they just have a deeper need for clinical data. All payers need it, but we've found Medicare and Medicaid really to be higher at the top of the list of folks who need it. So as far as what we believe about clinical data interoperability, CIOs want to focus on activating data for business use. So what we've heard pretty consistently on the payer side is, they work with thousands of providers across, hundreds of different EHR systems, and they really don't want to have to deal with going out and building all of these multiple connections, right? Like all the issues we've had with an interoperability on the different interfaces still exist today. Even in a world where FHIR is being rolled out, we still see pretty inconsistent implementations of FHIR on the healthcare system side and the EHR vendor side, at least for another year or more. So they need data from multiple sources, but they really want to focus on how they can make that data actionable for their internal users. So whether it be risk adjustment or HEDIS or care coordination, which is starting to become a much larger request, or doing the population health analytics, that's what they want to focus on, not having to go out and build 100 different interfaces or thousands in some cases. The difficulty, though, is that data has to be legally and technically accessible from across the entire care continuum. So it isn't just, the large healthcare system that you need data from all of the different specialists that a Medicare patient in particular sees. And it has to be legally available. So you have to have providers who are willing to share data for payment and operations purposes, because that's what payers need the data for in a value-based model. And then the second is that they need to deploy the data into their own workflows. So I will say, we believe that they need to do that. I will just be perfectly honest. And if any payers are on the phone, I'm really sorry if I'm insulting you. What we've seen sort of in the reality of the world is there's a lot of FHIR APIs, and one of the main benefits to FHIR APIs is that you can in fact deploy them into workflows. So you can more easily build a system that calls an API to do something as you're walking through steps, just like we do for every other technology area of our life other than healthcare. We've pretty consistently seen that like payers haven't really fully delved into how they can use FHIR APIs in the midst of their workflows to be able to go and access clinical data and pull it into what they're doing. So we're still seeing a lot of payers focused on like panel rosters and submitting those on the quarterly or monthly basis and giving a big dump of data versus, all right, I'm going through and I'm a case manager, like I'm a case management nurse at a payer. I found out my member just went to the hospital, let me go and pull their data into this care management system so I can figure out what I need to do, right? That's coming, I think, and certainly there are some very large payers who are doing a lot more of that. But we think, particularly as the payers move more and more into that value-based world, that's what they're going to want versus this like monthly or quarterly, let me give you my entire panel roster and you just tell me all the data you have. They're just consistently going to want more of that, like in their workflow stuff, just like provider side wants it in their workflow as they're managing their patients. We are seeing a growing demand for clinical data. So of the nearly 100 million medical records requests annually, which is an insane amount, and this is just from payers, it's around 100 million, 90 million are being fulfilled manually, right? So working with traditional retrieval services to go and make phone calls and get photocopies and faxes and things like that. It's insane. And on average, each physician receives 100 medical records requests per year, right? So if you think about a really large healthcare system with hundreds of physicians, that equates out to thousands of medical requests per year for all sorts of different things from payers. And I think we're only going to see that number increase. We are seeing an increasing appetite from the payer side for this clinical data, particularly because of the value-based payment models. If you have patients in an ACO that you're trying to manage, you're not going to be able to manage them unless you have their clinical data. I mean, there's just no way around that, because you can't recommend to them better care unless you know what's already happened. And so as we see those new models coming out from CMS and more payers participating in them, we just fully expect this to grow. And frankly, like, the manual world just can't keep up, nor can you take that data that you get manually and easily integrate it into your systems to do all the cool stuff that Summer's going to talk about. And so there really needs to be an increase in electronic data sharing. So from a payer perspective, there's a couple of different values that we see for them, particularly around electronic clinical data acquisition, which is really where our focus is. One, you can do much faster claims processing, reviews, and audits, right? So if you're if you're doing an audit of your provider network and you're trying to understand where the dollars are being spent, getting that data electronically in what amounts to near real time is obviously significantly faster than waiting the 30 to 90 days that you're going to have to wait if you're requesting that data manually. And then you have to go and extract all that data from the charts and have someone code it and do a ton of manual work to it. When you're looking at electronic clinical data exchange, the data comes to you coded and coded into the value sets already. And so it's significantly easier to take that data and use it. HEDIS and risk adjustment reviews, I will say these are still the top two reasons payers are coming to us. HEDIS and risk adjustment are the most important ones because obviously there's a lot of financial tie-in for providers on that. And really this, you think about the STAR, so 30,000 members, 50 million in additional revenue if you can just improve a half star, right? So there's a ton of payers who are looking for ways to improve their HEDIS and STAR measures. And then risk adjustment reviews are still just a ton of money out the door for payers. And so those are sort of the top two. The other thing that is increasing though, and we're seeing this a lot because we are getting requests from payers to do this, really is that care coordination effort. And so what we pretty consistently hear from the payers is, I want to do my HEDIS and risk adjustment, so I want that data on a monthly or quarterly basis, but I also want you to tell me anytime one of my members went in for care. So whether that be care within a hospital event, so they went to the ED or they went to inpatient, or even care out within specialty and PCP, they would like to just be notified that that care was received and then receive any pertinent clinical data so that they can do the appropriate follow-ups. And I think as, personal story on this, because I think it's always helpful. My parents are on Medicare, both of them. As you think about the last 2 years of COVID, which it's just feels so long, but as you think about the last 2 years of COVID, you have so many Medicare patients who got COVID, who went through care, who did hospitalizations or may not have done hospitalizations, but who now are sort of seeing the long-term COVID effects of things just suddenly going really wrong, right? So I use my lovely mom as an example. She had COVID December of 2020. She thankfully was not sick enough to be in the hospital, although my dad went in for a short stint, but she was like, I'm really, really sick, but then got better. And then last year ended up with acute necrotizing pancreatitis out of the blue, seemingly out of the blue, and ended up in a month-long hospital stay, then skilled nursing, then rehab at home. Now she's wonderful. So good news is miracle. She somehow lived through all of that. But the story there is the pancreatitis likely was caused by the COVID she had had months before. And then suddenly she's in the hospital. And I'll tell you because we were just talking about this week, the medical bill for her hospital stay alone was $90,000 charged to their Medicare. So if you think about the long-term effects of COVID, and the Medicare members in particular who had COVID and are now going to start going back in for care because they're going to start having events of the long-term damage of COVID to their body, payers are incredibly incentivized to get the clinical data so that they can keep those members out of the hospital. Like if they had been tracking what was going on with my mom, like we might have been able to avoid a month-long hospital stay because someone probably would have told her to go see a doctor much sooner than she did when the emergency happened. And so I think payers are looking for ways to figure out how to manage what is inevitably a sicker population for them because of those long-term COVID effects. And so while HEDIS and risk adjustment are the top two right now, over the next year, I fully expect that care coordination to become the much more important one. On the provider side, the benefit that they get from electronic data sharing is they get their claims paid way faster. And in fact, if we can eventually make all of this work, you can actually do almost real-time adjudication of claims, which amounts to a significantly faster payment time for providers. So that's a huge benefit for them. For the providers who are in those shared savings models, there's a potential for significantly higher shared savings because they're actually sharing the data amongst themselves and with the payers, and they're all managing the care of the patient together. We are right now working on some stuff around automation of claims attachments. So instead of having to submit your claim, then hear back from the payer that you actually need an attachment with it so that they know what they need to pay on it and they have the documentation, and then you have to attach it. It's a whole long workflow right now. If we could do automation of claims attachments where, you know, certain claims just you automatically pull the data because pretty consistently the payer needs it, that would make their payment much faster as well as more accurate. And then the last one, which is not to be not small at all, is reducing the burden on provider staff. So, you know, as we go out and we talk to providers and we sign data use agreements with them for this data access, you know, particularly because of information blocking rules, which is awesome that they're working, you know, they're seeing a significantly increased demand for electronic clinical data. So they're getting hit with requests all over the place. And their teams are stretched really thin. And certainly a lot of the healthcare systems are on like their third or fourth wave of COVID. And so while they're all stretched thin and they're trying to deal with COVID and they're trying to like do the right thing, they're getting hammered with these requests. And so we've talked to some of these healthcare systems where, you know, if you set up a connection with us, we can actually, in fact, reduce the burden on your staff, you know, like 50% for the HIM department. Like it's just pretty significant, particularly when we're working with large payers. So as we see increased demand for clinical data, being able to do it electronically via some of these standards-based methods is huge for them. And from a provider staff, and we'll share these slides with you guys so you have them. These are just some of the statistics that we pulled for fee. This is a fee for service model, right? So just in an FFS model, they can save like a ton of time, right? And be able to get more visits through the door. If you think about the value-based payment model or an ACO model, it's not just the I can get one more visit per day, but there's the potential for the shared savings because I'm actually preventing additional visits that a patient might not need if we were better managing their care. And so in an ACO model, there's potential for a lot larger savings than this. So for clinical data retrieval, like I said, the biggest we're seeing is risk profiles, right? So being able to do risk adjustment, and then HEDIS and quality management is the second biggest one. Care coordination is also coming into play. An interesting one that I at least find interesting is the member experience. We've actually had a number of payers come to us, and because of the CMS rules for Medicaid and Medicare providers to provide clinical data to their members, we've actually had a lot of folks come to us and say that they want to be able to access the clinical data so they can provide it via those FHIR APIs and get a better overall experience for their members. And I think particularly, again, in the value-based payment model, where you need that individual to engage with their care just as much as you're engaging with their care, I think that that's gonna start to increase as well. And then not surprisingly, operations is a little bit further down on the list. You know, there's a ton going on around electronic prior authorizations. There's a RFI that just dropped from ONC today because they're just dropping up stuff every day this week, it seems like, around EPA stuff. You know, I will just, in my cynical side, say, I don't know that the payers really want to speed up time to approve prior authorizations. I say that as because I take one of those migraine medication injections that cost thousands of dollars that I'm sure they would love to slow down the prior auth on. But that's a huge benefit for the provider side and for the patient side, right? So being able to speed up the prior authorization approval timeline, huge for patients in particular who need to get access to their meds, and for pharmacies who need to reduce abandonment rates. And then medical necessity, and last one, fraud, waste, and abuse. Value-based payment models don't mean there's no fraud, waste, or abuse, right? Hopefully it's lower because you're in a shared savings model. And if I'm being fraudulent, I'm probably not making as much money, but it's still a huge issue. And so that's one that we're seeing an increase in as far as payers wanting clinical data to support. And then I think this is my last slide, and I'm happy to answer questions. Our particular product in the market around this is called Clinical Document Collector. They shouldn't let me name things. Everyone should know that because Tafka was my name, and it's a horrible name for things. But Clinical Document Collector, the way that this tooling works is our customers who are the payers, they can either give us a roster file of all of their members who they're looking for data on, or we have a FHIR API that allows for search for one individual at a time. We are very excited for bulk FHIR. No one's ready for it yet on the payer side, and so we haven't put it into ours, but we will switch that out when that becomes available. But this FHIR API, you can actually integrate into your systems. And so the way that we sort of work with payers is, listen, if you're trying to do HEDIS or your risk adjustment, or you're trying to do an audit, give us your roster file, we'll go find your data. But if you're trying to do care management or care coordination efforts for your members, here's this great FHIR API that you can integrate right into your case management system and be able to do a call out for the clinical data for that individual. So we offer both of those options. Once we take in the demographics for the members that they're looking for, we use our identity management system, which I would like to say is, I feel confident saying it's pretty good and one of the best because of the way that we do it. But we match the demographics up against our database using a lot of our claims clearinghouse data for that match. And then we go out and use our, I hit the back button, our record location services to find that data across our entire network, and then retrieve that data in. Right now keep hitting my touchpad. Right now we are providing CCDAs. And so we can do any of the document formats. What we found is history and physical offers pretty much the most comprehensive data for what payers need, but we can provide back a bunch of different formats. And we hand off those CCDAs to the payers, who can then do whatever they want with them, right? They can make them human readable. They can parse them out and pull the vocabulary or the standardized data out of them and put them into their systems, and then use it for whatever purpose they want to use it for under payment and operations. And so that's just an overview of our system and what we provide. We've got a provider directory in there that helps us manage our endpoints as well as the access rights. So not everyone that we're connected to allows for all of the data rights we would like them to, but that's an ever improving process for us. So I'm gonna pause there because that's the end of my slide deck, but I think we have plenty of time for questions that folks might have, unless Summer has gotten on the phone. And Deanne, I don't know if I missed anything that I was supposed to cover, but
No, this is great, Genevieve. Thanks. I don't see Summer yet. I think he's going to be joining us closer to 1 o'clock. But yeah, I wanted to throw it open and see if anybody had any questions or comments. Genevieve, one of the things I wanted to ask you about was you mentioned that Tafka came out this week, and that really has been your baby since when you were at ONC.
I abandoned it, but yes. Yeah.
Right, and I just wanted to ask if you could say a few words about where it landed, what your hopes are. I know a lot of the details are still coming out in terms of the standard operating procedures.
Yeah. So the first thing I would say is, and I follow Twitter, so you always have to take a grain of salt what people say. And there's certainly folks out there who feel like Tafka is totally unnecessary. It's so 1990. Why would we do any of this? Like you guys are crazy. And I would just, the first thing I would always say is like, especially since I left ONC, I was in the real world before I joined ONC and had a lot of experience with HIEs. And then since leaving, we work with a lot of networks, right? In order to access data for the payers we're working with, we have to work with networks as well as direct connections. And, while the networks have worked very hard to make interoperability a reality, there are still very large gaps. And they are the same gaps that were there 5 years ago, which is why I wanted to do Tafka. And so what we've seen pretty consistently is when it comes to payment and operations purposes, which really is almost the only reason a payer can ever ask for data, right? There's there's a little bit of like if you're supplemental insurance, it's slightly different, but as a payer, payment and operations, even if you're doing care coordination, is how you request data. And what we've pretty consistently seen from a network capacity is that almost none of the networks can really do payment and operations at a broad basis because the members aren't opting into it. And some of that's the provider side of like, they're still just not comfortable with payers having that level of clinical data, which again, in a shared savings model, I think it's a little bit different calculation, but they're not comfortable with it. And so they're not like gung-ho about it. And then, and please don't tweet that I say this. I know this is private meetings. Please don't tweet what I'm about to say, but like, there are a number of large EHR vendors who have already created or are creating these payer hubs, and they're charging a premium for that data access that otherwise, under Tafka would be equivalent to almost free, right? Like commoditization of that connection. And so what we've seen really consistently is, as much as things should work between networks today, after 5 years of starting Tafka, there's still just those gaps around like, they don't want to support payment and operations. There's still a major gap around individual access and providers not agreeing to individual access. There's some gaps around patient matching and having capabilities there. And so like when you make a request through Commonwealth and it crosses over to care quality, we're not seeing great return rates, and vice versa. If you're in care quality and you're crossing over Commonwealth, they're not seeing great return rates either because of the variation in how the matching is being done and who's doing it. And so I do think Tafka is taking steps towards fixing a bunch of those gaps that still are just out there today that there's really no incentive to fix right now because of all the other stuff going on, right? So I'm overall happy with what's in it, especially because they fixed some of the concerns that we had in our own comment letters put out there around like setting SLAs for data return. So like if you're not going to have a centralized infrastructure to do matching and record location, that's fine, but then you need to set really strict service level agreements around return rates. Otherwise, you're just timing out the network over and over and over again, and you're not really getting any data exchange, right? So I think they plugged a bunch of those holes. I think what they did on FHIR was super smart because, again, I've worked with that in a network capacity. It does not work as easily as everyone thinks it should. But if we can get to a point where we actually have brokered FHIR in a network capacity, we actually can get to scale with FHIR, which we can't right now. Like we legitimately cannot get to scale because of like the data use agreement piece of things and all of that. So I think that was good. I was very disappointed that payment and operations was not required because that's like a huge one. And what I've seen consistently throughout my career in this space is like, until you make someone do something, they just don't do it, right? So in the value-based model, and we've seen this with a couple of health systems we've talked to. If they're in a value-based model, they're actually pretty willing to share data with the payers for payment and operations and sign up. But if they're not in one of those models, they're like, why in the world would I make it easier for the payers I don't like to have this clinical data, right? Like they're really worried about blowback on themselves, right? And so I think that's a gap that they're going to have to plug pretty quickly. And then definitely we need to see some of the SOPs. I'm really excited about individual access being required, but until we see the SOP for how they've set it up, I would say this: if they set it up the same way we finalize the care quality implementation guide for it, then we're going to have an issue because we won't just be able to query and find the data on a patient. You're going to have to use the whole Smart on Fire with portal credentials. And that's a trash option for patients. So that sounds mean. It's a great option in a world where patient matching can't be done, but it can be done. So yeah. Mm-hmm. So that was I just said a lot of stuff. So I'm happy to answer questions. I think I saw one in the chat, but
yeah, there's a question about does the FHIR API have capabilities to get patient data from any HIE in the US or integrated with only a few HIEs in the US?
So the FHIR API that's sitting at the front of our solution is the FHIR patient resource. And so it allows entry of the demographics into our system. We can only access data from the data sources that we have data use agreements with. So we are a participant. So in addition to being the service provider for Commonwealth, we also are a participant. So to the extent they're connected to Commonwealth and care quality, we would access those networks. We are in talks with at least 2 HIEs around accessing, integrating with them for data access. I did a fairly thorough review of HIEs and what we were personally looking for as Change Healthcare for our product was HIEs that allow for third parties who are acting, who are a business associate acting on behalf of a payer to join, who have payment and operations in their data use agreement. So, you're allowed to request for those purposes, and who have CCDAs, not just ADTs. And there was actually only about 5 HIEs in total that met all 3 of those criteria. There were more that had CCDAs, but a lot of them have not been able to expand to payment and operations because their participants have not allowed them to do that. So we're in talks with a couple of them. And then in addition to them, we've got connections directly with EHR vendors. So we're connected with Allscripts, Practice Fusion, NextGen, Athena. Our Epic app just went live 3 weeks ago. So we're doing a pretty heavy effort to connect with Epic folks as well. Yeah.
Great. Thank you for that. The next question is, do you see the FHIR Care Plan resource as useful for payers?
I think it could be. So I think where I've been a little bit frustrated on the FHIR side with payers is we would love to use the DaVinci FHIR specs and be able to give them the care plan or do the EPA or do, I think it's HDEX, I think is the acronym. At least the payers that we've talked to, and I will say, I'm going to set aside the 3 or 4 really big ones. They are not ready for FHIR. They don't have it is actually just a people issue. They do not have people who are FHIR experts who can build the APIs. And so a lot of the conversation we've had to have on the payer side is, hey, we give you a FHIR API, which is great. You still have to build your side of the FHIR API. So I think a lot of them went into it thinking oh, it's an API, I don't have to do anything and we're done. Not realizing that they still have to build their connection to the API and follow the spec and all that. So I actually think that the FHIR Care Plan resource would be very valuable to payers because it contains so much of that care plan data that we've heard is really valuable, and a lot of it in a coded way. Maybe we're not talking to the right people, but I think we've only run into one payer who actually wanted FHIR. And everyone else was like, we'll just take an SFTP, please, which is a little sad. So
thank you.
Yeah, it's a little depressing. I was kind of really sad about that. So
yeah. One question I had, and I wanted to get your opinion on this, is, universal patient identifier. And it seems like every year we get a bill that goes to take the restriction on funding off, and then it just dies somewhere in conference or it just dies in the Senate. And it seems like there's hope this year that it might get passed, but as we all know, Congress left in December and didn't get what they were supposed to get done anyway about a bunch of things. So,
yeah,
is this really a hindrance to where we need to go with interoperability without it? Would it help? Just wanted to get your thoughts on that.
Yeah, I think my thoughts on it, which is probably why you asked me. But so it's one of those things that to me, it's a straw man validation for why we're doing poorly, right? Like, so to me, it's an excuse for where we're at. So listen, if we had done a unique identifier in 1996 when HIPAA was out, my answer would be totally different, right? But we didn't. And what I still just can't figure out, and no one will answer, is, okay, so it gets removed, the prohibition's gone. Okay, who's funding it? Because it's billions of dollars, if not trillions. How are you going to identity proof every single American citizen, and not just citizens, but like other people who are here, like on green cards, right? Who are using our healthcare system. So how are you going to identity proof them? Keep in mind, you cannot electronically remotely identity proof anyone under 18, because you can't use biometrics for anyone under 18 based on the law. So how are you going to identity proof everyone? Number two. Number three, which agency is going to do this? Like, there's going to be a fight between SSA and CMS, I'm sure, but like CMS doesn't oversee all of healthcare, right? So which agency is going to do it? And then four, like, how are you going to address fraud, right? And I still remember, I think it was the year before COVID, probably the last in-person ONC meeting that we had, one of the guys from the NIH in the UK spoke, and he talked about patient matching and actually indicated that even with unique identifier, they still have problems. But one of the things he said that I had never thought about until then was, like, in the UK, where you have a single payer system and guaranteed healthcare, they don't have to deal with fraud, right? There's no one out there stealing someone else's identity so they can get healthcare for free, because they all have healthcare. So how in the world in the US, where you're not guaranteed healthcare, where we already have fraud issues within our space, are you going to ensure that as you're assigning this unique identifier that is now going to be used across the entire healthcare system for every single thing you do, that you're not having fraudulent assignments, right? Like, there's a massive issue. And so, like, my frustration tends to be, like, people look to that as like our hope of, like, it'll solve all of our problems. I don't personally think it's operationalizable, implementable, whichever word you want to use, with where we're currently at in the US. Now, I've heard some people say that, like, you just do it like sort of on a go forward basis, which I think would be fine, but then it's also still not going to solve your problem, because if you're only doing it for children born like this year and forward, like, we're all going to live for a really long time still. So how do you address that? So that's sort of my frustration, is like, you can focus on getting that removed, or we could just talk about better ways to do matching and setting some actual standards that people have to meet in order to improve match rates. I will say we did a pilot last year with individual access, and granted, these are people who are easier to identify. But we had about 30 people go through, get identity proofed. So like almost everyone passed the identity proofing, which was electronic in nature. And we actually hit a 72% match rate using a straight 100% match, because you have to for individual access. So it's not like 100, right? We're never going to get there. But if we could set some rules and people follow them, we're going to get above 90. And I think that's about all you can kind of hope for when it comes to matching. So that was a really long-winded way of saying, like, cool, how are you going to do it once it's done? Yeah. And if you have brilliant ideas on how to do it, I'm open to it. I don't know. I think about it.
Well, I appreciate your insights there, because it really is an interesting political conversation, because not only is the funding restriction, basically the government right now, unless there's legislation to change it, is not allowed to fund a universal patient identifier, but then it's also a very big issue with a lot of provider groups. Hey, Luna.
Yeah, she's like, I would like attention now.
Yeah. You know, Chime is very supportive of this. A lot of other provider groups are, and I understand everyone's frustration, but I think if you think about how do you operationalize it?
Yeah. And like the other issue too, right? With Real ID, think of how many states sued the feds over implementing Real ID, and we're years and years and years later. I mean, it's been at least 10, I think, and there's still a handful of states that haven't implemented. So do you really think Texas isn't going to sue the federal government over like the unique identifier for healthcare? Like, so I think like that's the other issue, is you're going to be in years of litigation. And again, it's just my feeling is like, let's focus on stuff we can actually do. I think I was really excited that ONC put out the US project specification. I think standardizing address, we've seen huge boosts. That was one of the recommendations from 2013. See, these calls, Deanne, are depressing because I realize how long it's taken anything that I've ever done in this industry to get done. But that, like, doing those kinds of practical things, setting some standards, doing some like national testing, I think is really the better pathway, in my opinion.
Yeah, I agree with you. It's kind of like the conversation everyone's having about privacy of data outside of HIPAA. And while they're not getting anything done in the last few years on the federal side, it's more data is appearing every single day. And so now you're going to have to retroactively put those guidelines in place.
Yeah, I agree. And I will say on Tafka side, I was very happy to see that they kept the policy of like holding those non-HIPAA organizations who have individual access to our standards. And they did it not just for the data they acquire via Tafka. They actually said any individually identifiable data that you hold, you have to basically use the HIPAA cybersecurity standards for. And I thought that was actually a really good thing, personally, because it gives at least a little bit more protection than you have now. And the benefit on the app side is you're getting significantly easier access to the data that you're trying to use. So it's, it's kind of a bit of a quid pro quo on that one. So.
Right, exactly. Anybody else have any questions? If not, Lloyd Brodsky, if you're on, I was going to ask you to give us a little bit of a preview for the February session.
I actually had a question.
Oh, go ahead.
Hi, this is Richard Singerman. Could you talk a little bit more about FHIR and the limits to scaling because of the data use agreements?
Yeah, so FHIR is a technical standard. It is not a policy standard, right? So if I want to connect to a FHIR API that's sitting at a healthcare system or that's sitting at a payer, I still need the legal agreement in place that enables access to that API. So I can't just go, so let's set aside the individual access use case, like leave that one alone because that follows totally different rules. And I think that's where people mostly think about it. But when you're trying to do B2B exchange, the business to business or covered entity to business associate or CE to CE, in that scenario, I can't just go to you and access your data absent a legal agreement that entails how that data is going to be used. And so even if you have all of these FHIR APIs that are standardized, which they're not right now, but even if they were all standardized and available, I would still have to do individual data use agreements with every single FHIR API endpoint before I could access that data. So that's like one limitation. I think the second limitation is it's not plug and play. So even if you're using a standard, now FHIR v4 is closer to plug and play, but there's still like work I have to do to actually connect to that API. And so like that's sort of the other scalability issue is when you're talking about thousands of FHIR endpoints from a payer perspective, if I have 10,000 providers in my network, that's potentially 10,000 FHIR endpoints. And if I have to connect to all of them, that's still a pretty heavy technical lift versus in a network capacity, having the network go and do all those connections and I only connect to one place. So I'm a firm believer in like networked FHIR, have been for a number of years, and but there's differing opinions on some of that. So,
Well, but what about the scenario of companies coming along and say, okay, well, I'm going to aggregate 10,000 or 100,000 individual people's permissions to get access?
Yeah, so that's like such a different story because in that one, you cannot require that third party to do a data use agreement with you. But the flip side is it's Jennifer, hey, you're going to be using the smart on FHIR. So like from a legal or ONC info blocking perspective, what they're required to provide in that scenario is the smart on FHIR with portal credentials. So you can go and you can aggregate that and you can access the data via that smart on FHIR API with no data use agreement, but you're gonna be a little bit limited in like what you can do. And we've actually seen in the rollout of that, a bunch of healthcare providers, are like making that view only instead of like actual ability to pull the data. Yes, please. Yeah. Does that make sense? Like
it does. But if it's view only, does the person viewing still have an opportunity to extract what they're viewing in a structured data form? Or
so I'm not sure, to be honest, because it's some implementation decisions that healthcare systems have made. And I'm not sure, honestly, like if there is an ability to pool the data and extract it yet. I think with V4 and with the data extraction requirement that's coming through certification, that might change. But what we've heard is a lot of folks are just making it like a view so that that third party doesn't actually like have the data itself. Does that make sense?
Yeah, no, it does. So thanks.
Yeah.
Thanks, Genevieve. I see our other speaker, Summer, has joined. So Summer, welcome to the group. If you want to go ahead and load your slides. But as I mentioned, Summer is a doc and he also leads our value-based analytics team.
Dan mentioned, I'm an ID doc by background and I was in clinic this morning, so that's why I'm running a little behind today. But it's a pleasure to meet everybody. I'm VP of Value Analytics at Change Healthcare. So I'll go ahead and dive in. In terms of value-based payment models and overall what we tend to call value-based care, there's a number of elements that are technology and ultimately then driving the technology-enabled services that we're seeing evolve out there. And in many cases, it's taking things that we've historically done in a fee-for-service environment and translating those into more of a value-based care environment. So as I talk through a little bit, for me at Change in our value analytics business, we tend to primarily work with payers as our customers. And in particular, a lot of what we do is analytics that support payers in terms of value-based care programs and some of the activities that drive into successfully standing up and performing those programs. And oftentimes what we then do is kind of work with those payers to drive those insights out to providers in a variety of ways to kind of facilitate the dialogue, facilitate performance, and really create more of that collaborative concept that tends to be more successful in delivering value-based care. So I'll touch on just for a moment, the way our group is built. We look at risk adjustment, alternative payment models, and quality really as concepts that have tended to exist as sort of standalone operations or functions oftentimes in a health plan world, but that are really closely related in the sense that often the same kind of data is used to drive these various activities, but also the activities themselves really tie into each other. So, as you look at a health plan that wants to move into an APM program successfully with a group of providers, step one really is being good at risk adjustment, understanding through appropriate documentation, the complexity of the patient population that you're aiming to manage, the budget and actuarial models that tie towards appropriate utilization, really trying to get a strong sense of what is the value and what are the metrics that you would want to meet in order to consider a contract viable and ultimately successful in moving into alternative payment model. So then obviously as you move from there into planning, contracting, and then operating an alternative payment model, whether it's an ACO, bundle payment program, patient-centered medical home, or a variety of the other types of models that are coming up these days, the analytics that then drive into being successful depend heavily on appropriate access to data and modeling based on that, and that data being as accurate as possible and reflecting what really is happening with the individuals in that population. Then ultimately, as we look at that transformation from fee-for-service to value, inherent in value is the idea of delivering outcomes and quality. So as you look at the idea of HEDIS measures, star ratings, really looking at the idea that oftentimes that's a standalone function today. Increasingly, a number of contracts are being written where there's gatekeeping mechanisms or pay-for-performance mechanisms tied to quality. And as we move deeper into the more advanced models, upside, downside risk, and ultimately into global risk, the idea of being able to align quality directly with performance in an APM becomes increasingly important in being successful with more advanced risk models. And then, of course, It all ties together and resets by performance year every January 1. Now, inherent underneath this is all the data in the world is great, but if you're not measuring the same things the same way using common standards, you get different output. And so that's where, when we look at value-based care models, ultimately there are a number of different types of models out there, but there's different models even with Medicare, individual state Medicaid plans, commercial plans. There's a lot of discrepancy from one area to the next, and it's been a problem for both health plans and providers to really scale out these programs effectively, especially when a data-driven program can be very effective, but you can't really sort of compare one set of data versus another effectively. So that's where standards really come into play. So with risk adjustment, there's a number of standard models, whether it's through CMS or through individual states who have endorsed certain risk adjustment models like CDPS. With quality, obviously NCQA HEDIS is really, for the most part, the gold standard there, but there are a number of other quality metrics that are out there as well. And I'll talk a little bit about some of the standards behind alternative payment models, and in particular around episodes of care, bundle payment models, and some of the pieces that feed into that. So in terms of episodes of care, for those who aren't familiar with that concept, the alternative payment model programs that tend to go with episodes of care are the bundle payment programs. So if you're familiar with the BIPSI program and Medicare, there's a number of Medicaid and commercial programs, in some cases direct-to-employer programs that operate on a similar concept. Essentially, it's a model that was designed primarily to engage specialists in acute care facilities, and in acute care facilities, oftentimes specialists as well. So in that scenario, if you balance that out with the ACOs, which have often been PCP driven, this was really a concept and a set of models that were really focused on the idea of specialists, and even more so specific service lines for a specialist. So when you think about an episode of care, it can be a surgical procedure, like a knee replacement or a heart surgery. It can be an acute condition, heart failure admission, acute MI, that sort of thing. Or it can be some other procedural type episodes, maternity, delivery, colonoscopy, things like that. In the end, the idea is to really have a clear definition of what that service is in order to then effectively measure performance, one service against another, one provider against another, one member against another, so that you have a consistent standard going across that. So inherent within those standards are the definitions of what is an episode, what are the triggering criteria, the code sets that tie into the analysis, and the conditions or complications that then tie into the idea of appropriate utilization. So if you think about somebody with a knee replacement as an example, so what's the definition of a knee replacement so that we all have the same definition? What are the triggering events to say a knee replacement has happened? And when you look at data, which data sets to look at. What are the code sets that align to a knee replacement so that we say we're all looking at the same thing? And then also, what are the code sets that align to the complications? So whether it's sepsis, bleeding, some other sort of avoidable complication, we can really look at those in a standardized way so that when we do an analysis, we're able to not only compare across these various episodes and providers, but also really kind of focus an operation to understand where are the areas we need to improve based on what the data is telling us. So this is a screenshot of one of our products, and I won't go into the product so much as just to kind of show the idea of what kind of information is here. So if you see what's kind of blown out here, this is a maternity episode of care. You can really see, when you look at the number of episodes and the average cost, you can look at that, again, for one provider across their population. You can look at it across the whole population. So you can really see what's sort of typical or average, and then get a sense of benchmarking, who's above average, who's below average. And same way, when you look at the cost drivers, if you see that box in the middle, this ties back to those standard code sets. So what is a diagnostic image that's appropriate for a maternity episode? You can really go back and kind of tie together the individual data points that help show you what performance looks like. And again, as you drill down deeper and understand the complications and the factors that tie into cost, what are the differentiators that drive those outcomes? So in general, many of you may be familiar not only with the idea of episodes of care, but with groupers that, support that concept of episodes of care. Where we've really embraced the idea of having a standard is around the idea of Prometheus. And for those who aren't familiar with Prometheus, it was created initially by a nonprofit collaborative about a decade ago, where they set out specifically to create a standard set of episodes of care that could be transparent to folks in the industry and be created in a collaborative way with a lot of input from various stakeholders. So the idea here was to create something that is transparent as opposed to sort of a black box where there's a lot of criteria that are sort of proprietary and difficult to see or understand. So when Prometheus was initially created, it was really created with the idea of not only kind of creating that standard, but creating the transparency behind it. And so it's now, over the past decade, become very widely adopted by a number of health plans, particularly in the commercial and Medicaid space. And again, going back to the comment about the BIPSI program earlier, Medicare has its own sort of set of criteria and measuring sets for the BIPSI program. So really, this is kind of the everybody else standard, for all the commercial and Medicaid plans that are out there. So there's a number of states that use it for a variety of purposes at the state level. We'll talk about Maryland in a little bit and one of the projects that they're doing, as well as a number of commercial plans where they want to set up commercial episodes of care. So you can see the stats there in the lower left about the current utilization of it. I won't go into that in detail. The key I'll say is that because all the information is made available for the end users, and that's not just the health plans, but also the providers, it really facilitates the conversation, both in terms of when the contract is created, and a lot of health plans will actually cite specific elements of these criteria in the episodes of care as part of the contract, what's in or out, so to speak. And then also when they come to operate and reimburse, there's less of the bickering over, I'm right and you're wrong, more of, let me show you how we got to that number and let's work on doing better next time, or let's work on optimizing what we've done. So that transparency has been critical in really driving it forward as a standard for both payers and providers who use it around the country. Now, kind of correlated with that is a collaborative approach. And so, again, I won't go into detail here, but ultimately, this idea that it's transparent, that providers can go look on the website, search the code, look at the definitions, and work with health plans to help better understand the analyses. That's coupled by the idea of a governance model that's collaborative across the industry as well. So there's an advisory board behind it with payers, providers, subject matter experts, and outside clinicians as well. So you have kind of a broad collaborative view. And again, this oftentimes, really ties back to the concept that has slowed down the adoption of value-based care in many environments, which is, that sort of lack of transparency, lack of trust between payers and providers to say that, we're measuring the same thing and ultimately paying based on the same criteria. So the idea that there's broad collaboration, broad stakeholder input so that it's applicable across broad swaths of the population, and also the transparency to where it's constantly able to be viewed, vetted, and updated, that really drives a significant amount of success for the payers in the states that have been working with it in a way that allows them to really kind of get to the next level of conversation of how do we do better. So, in terms of the way the analysis is done, again, I won't go into this in detail. One of the key elements here is what's in the red box here, potentially avoidable complications. And potentially is critical because not all complications are avoidable. There are never events, but the idea of potentially avoidable complications and being able to measure and compare those across populations and across providers is an important element to kind of supplement quality. So we talked earlier about the NCQA standards around quality. What we find increasingly is health plans are interested in looking for other ways to really depict value. And one of the ways to depict value is this idea that you're avoiding things that could be avoidable. So oftentimes in a particular geography or a particular network, there's a variable sort of acceptable baseline of avoidable complications. And there's a risk adjustment sort of methodology that ties into this as well to account for variability in the populations as well. But the idea there is that at least you can compare and you can say, well, at least, if you say this happens to everybody, well, no, it doesn't happen to everybody. It just happens more to your patients than everybody else. And let's figure out why that is. Now, I'll touch a little bit on the Maryland EQUIP program, and then I'll kind of stop and we can do a discussion and Q&A. For those who aren't familiar, the agency in Maryland, HSCRC, they've set up a program that they call EQUIP, which is a program around episodes of care and quality improvement. And one of the unique things about this program, it's being operated at the state level, but it's a program that actually ties to Medicare patients in Maryland. So it's a program they're doing to really kind of understand not just how those patients perform within the state and within those constructs, but also really to kind of get a sense, is there perhaps an opportunity to advance upon what we've been doing with BIPC and the Medicare programs? I think there's been a lot of success in the BIPC programs, but I think there's also been an acknowledgement from CMS that there's more we can do there. There's more opportunity to continue to deliver value. So, as you can see there on the right-hand side, there's a set of key episodes that are a part of the Prometheus set right now. And actually, we've been having conversations about adding a couple more episodes. There's some interest around emergency department and efficiency of admissions and perhaps also frequent flyers and, ER docs showing an interest in getting involved in sort of delivering value in various ways. So there's a number of opportunities that are radiating out of this in addition to the program itself to engage a broad set of stakeholders and really understand how can we do better as we all kind of continue that journey to value. That program performance year just launched a few weeks ago, so they're very early into the program. But this is one that, it'll be interesting to kind of see with their Medicare population, how things pan out across these various episodes. And I think a lot of states are really kind of keeping an eye on this to better understand, what is the applicability, not just for Medicare patients, but even for other programs that states may operate that could, again, bring value to a variety of stakeholders, whether they're Medicaid, commercial, or Medicare patients. So that said, I know I've rambled a little bit and would love to kind of open up for any questions and comments and discussion from the group. All right, so maybe I'll ask the group, are you all familiar with Prometheus? Have you encountered it previously as a standard?
I'll ask a question.
Sure.
Hi, this is Dr. Richard Singerman from Day-to-Day Health. We're part of Babylon Health now. Question for you. So what kind of research projects are you doing to do early validation, let's say in Maryland, of these kind of initiatives? And, who do you partner with to do these projects? Let's say digital health companies or specialty care companies. And the reason why I ask that is in a conversation I had on this topic not too long ago with the chief quality officer from certain hospitals in Southern California, they were really saying, you know what, we really don't believe there is such a thing as an episode of care. Patients are so different, you can't bucket them like that. So I'm wondering, what's the feeling in the industry about that concept as well? So 2 questions.
Sure. So, I'll say for the first part of the question, there are a number of different provider organizations, and I'll use that term loosely, that will typically engage around both development and utilization. So, obviously there's the traditional sort of health systems, IDNs, those sort of groups. Increasingly, we're seeing an interest among sort of niche disease management companies. So, companies that are stood up specifically to manage, for example, one we work with is managing OCD, obsessive compulsive disorder. Another one that's managing inflammatory bowel disease, IBD. So we're increasingly seeing, these sort of specialist chronic disease focused programs that are coming up where companies are sort of operating as providers, but really almost as technology-enabled service providers focused on really enhancing the experience of a focused subpopulation that perhaps is underserved or under-recognized. So increasingly, we see an interest in trying to understand how to hone in on those folks. I'll say the other piece that we see, episodes of care has traditionally been sort of tied to the concept of bundle payment programs. Increasingly, we're seeing an interest in specialist-driven total cost of care models. So if you think about the CMS constructs of the oncology care model or the ESRD model, those I think are kind of early efforts along this line. But we're seeing an increase in interest in using this idea of the episode of care more towards sort of chronic disease management by a specialist. So, one example that pops up quite frequently actually is osteoarthritis. So number of orthopedics has been one of those areas that's really embraced the concept of bundled payments. So a number of orthopedic organizations, including, a couple that are fairly well backed, with fairly large resources, are interested in saying, we've done pretty good with, acute procedural type bundles. What can we do to get involved more in chronic disease management? So OA, RA, how can we sort of demonstrate that we can also provide value in helping manage these diseases without requiring surgery or only going to surgery when there's a need to do so appropriately? So increasingly, that's where the shift really has been. Frankly, in terms of bundle payment programs, there's a lot that's been done, but there's not a rapid proliferation of bundle payment programs out there. The ones that are operating are doing pretty well and they're stable, but we don't see this sort of raft of new bundle payment programs being stood up. There really is an increasing interest in this idea of specialist-driven total cost of care models, or more heavily integrating specialists into the ACO type of model. And again, I think from that perspective, it's sort of the limitations of the PCP can only control so much, can only do so much. And in the end, you really need the specialists engaged in those kind of models to be effective. And again, particularly as you see that move towards global risk in population management. The latter piece of what you mentioned in terms of the skepticism of whether episodes of care really have value, I think that's something I've heard, but at the same time, I'll just give you my opinion here for what it's worth. In some ways that can be a deflection to the idea that there is a standard. So as you well know, we far too often in healthcare sort of fall back on this idea, well, I'm different, my patients are different, my practice population is different. They are a little bit, but again, that's that collaborative model to say, well, if 80, 90% is pretty much the same, we can kind of better characterize what these services are. And I'll say where it's really actually coming into focus, even beyond sort of these alternative payment models, is the idea of moving into, comparative analytics, consumerism, price transparency. So when you can better define a service, let's take a knee replacement. So if a knee replacement is clearly defined from one place to the next, so from my location in Florida to a hospital in Southern California, for a consumer or someone who's trying to compare, it's clear what you're looking at. And I use the analogy, it's not even apples and oranges. It's, are you looking at a green sour apple versus a green sour apple, right? Because obviously apples are different too. So that is increasingly, even for those organizations that aren't so interested in alternative payment models, and as you referenced, may not really have fully embraced the idea of value-based care yet, if they've embraced, consumerism, transparency, even just comparative quality, the idea that, my place is a better place to get a knee replacement than their place, having that sort of definition and standard to run those analyses is becoming increasingly important.
Great, thanks.
Sure.
Joe, I think you have a question. I know you put a link in the chat.
Yeah. So Summer, we had a discussion earlier on the issue of patient-centeredness and provider patients having shared stated goals in a care plan, and we also talked about the issue that is particularly Genevieve, that the getting the provider community, the payer community actually, to use FHIR is is a ways off. So this week I'm attending the working group meetings for HL7, and in the Da Vinci section, there's been a further discussion about risk adjustment as one of the services that they could stand up using the FIRE model, which has disciplines around the content definition for patients and cross uses across a lot of different issues. I'm curious on your thoughts on, you mentioned this earlier in your presentation, licensed models, black box models, models that are used by CMS, and having a level playing field. So do you see that a standards development organization has a role in risk adjustment?
I do. So I think it's a great question, Joe. So I do. I mean, I'll be honest, we support, I think, at least a half dozen different risk adjustment models based on the variety of either federal or state regulations and which ones certain government plans have endorsed. So even where there's quote unquote standards, you're talking about a half dozen standards that vary from state to state or from state to federal. Absolutely, I think there is an opportunity there to standardize risk adjustment. And I'll say where it's a problem, and I've experienced this firsthand, and I'd be curious if others have as well. You know, I mentioned I ran a couple of ACOs at one point, and, you know, what we would do is we would sort of do our own analytics because, of course, you know, we were smart and we needed to do our own. And, you know, in some of our risk contracts, we did Medicare, Medicaid, and commercial risk contracts. And in some of our risk contracts, we would think we were doing really well because we do our analytics and we had our own risk adjustment model and our own quality calculations. We thought we were doing great. And then you get to the end of the year and you're done and high five, we hit all our metrics. And then, you know, the next year comes where you get kind of a readout of your performance and yeah, you lost money. You didn't hit any of your metrics, you know, you don't get a shared savings. So, you know, that was frustrating, but it's also born of the idea that, you know, as a provider organization, we weren't using a standard. And I don't think we appreciated at the time that we weren't using a standard. You know, we just thought we're doing risk adjustment and we're doing quality, you know, and I think that's where, to your point, you know, there are a number of entities that are multi-state, you know, operate in multiple environments. And again, if you want to have a relatively standard operation, but you're being measured differently from state to state or from line of business to line of business, Medicare versus Medicaid, it matters. It does, you know, it impacts your operation because you're not actually doing what you think you're doing, or you're not seeing what you think you're seeing. So I do agree that there is absolutely an opportunity to look to standardize. You know, all the models have their pros and cons. In the end, none is perfect, none is terrible. But, you know, certainly I think there's an opportunity to harmonize across them.
That makes sense. Thank you.
Sure.
I think we have time for one more question. Any other questions? Well, with that, I'd like to thank Summer and Genevieve for joining me today. I really appreciate it. And I'd like to say that even though we work at the same organization, I learned an awful lot about stuff that I didn't know before. So thank you.
Okay,
Thanks
so thanks to everybody for attending.
Yes,
thanks to our presenters. I'm going to stop the recording, but we'll carry on. But just for the purposes of the recording, thanks to everybody that put the program together.